So there was some question regarding the waterfall phenomenon. So regarding the waterfall phenomenon, there are two things. One is the bicarbonate excretion that happens in the kidneys. In decay, what happens is that when the bicarbonate reaches the level of 12, the kidneys almost stop excreting, like almost it is zero. After that point, there is a steep fall. So that is something. And if you're talking about the renal threshold for glycosuria. So in that phenomenon, in that aspect, the renal threshold normally what they say is around 180, beyond which there is a excretion of glucose which begins. So it is not that all nephrons are simultaneously starts excreting. It's heterogeneous phenomenon. So there is a small curve and then there is a steep fall. I mean, there is a gradual increase. So that is also known as a waterfall phenomenon. So let's go to the other topic in thyroid. Uh, Hope everybody is okay to continue, not exhausted. You're able to match with the classes and able to listen to. Yeah, okay. Thank you, Dr. Kushbu. So, regarding thyroid hormones, before going into the specific topics, small brush up on the basics. Okay, thyroid hormones normally stimulated by the TRH, which is produced by the hypothalamus, then the TSH, which is produced by the pituitary, which stimulates the thyroid gland uh, to produce T4 from iodine and thyroglobulin. So the T4 is produced in the thyroid gland. In the peripheries, T4 is converted into T3 by deiodinases. Okay, this happens in the peripheral tissues. So most of which is active actually. T3 is the most active form and some of T4 gets converted into reverse T3 as well. So when we are terming the disorder, if the disorder is primarily in the thyroid, it is primary disorder. Secondary when it is related to the TSH, and tertiary when it is related to the hypothalamus. So when you're interpreting your thyroid functions, look into free T3 and T4 and your TSH levels. So if your TSH is low and your free T3 and T4 is low, it is problem with the central pituitary, that is central hypothyroidism. If your TSH is high and your T3, T4 is low, then the problem is in your thyroid. Okay, there is a feedback mechanism wherein your TSH is increasing to produce more T3 and T4. So the problem is in the thyroid. So if your free T3 and T4 is high and TSH is low, it is primary hyperthyroidism. If both free T3 and T4 as well as TSH is high, it is secondary. Okay, secondary hyperthyroidism. So that is the basics. So these are some values. Okay, the TSH value being 2.5 to 5 international units per liter. So T3 is the metabolically active form. So most of it is from T4 due to peripheral conversion. And most of these T3 and T4 are bound to thyroxine binding globulin. Okay, so just remember that aspect. So we'll go into thyroid storm directly. So what is it? It is acute life-threatening form of thyrotoxicosis or a decompensated hyperthyroid state with multi-organ failure. Mortality is up to 7 to 30%. Okay, etiology, it can be due to any precipitating event like infection, trauma, DKA, any surgery, thyroid surgery, any accidental or intentional overdose of thyroid supplements. So how will you diagnose? First, the clinical picture. What are the findings you will have? Patient will be febrile with hypothermic, like the temperature can be very high as 40 to 41 degrees with diaphoresis. Neurologically, patient will be in altered sensorium, agitated, psychotic, okay, or it can be the other way also, stupor, coma. And cardiac wise, tachycardia, tachyarrhythmias, especially atrial fibrillation, ventricular fibrillation, there will be a high cardiac output state, hyperdynamic circulation. And the patient will have high systolic blood pressure, systolic heart failure, leading into pulmonary edema also. Okay, GI, diarrhea, nausea, vomiting, abdominal pain, the liver can be affected. There will be altered liver function test, jaundice, and hepatic failure as well. Patient with chronic features will have weight loss, goiter, exophthalmos, tremors, so all these things. Labs, when we look into the labs, there can be elevated WBC count, there can be mild anemia, thrombocytopenia, not very common, but thrombocytopenia can also be there. And the creatinine kinase can be elevated, resulting in rhabdomyolysis and acute kidney injury. The LFTs will be deranged. There can be abnormal elevation of the liver enzymes and bilirubin also. There can be hypocalcemia, hypercalcemia, there can be hypokalemia associated. Cardiac markers can be elevated. Okay. The thyroid related tests. So when you are looking into T3 and T4, both T3 and T4 levels will be elevated and TSH will be very low or undetectable. Okay. Also, there will be associated hyperglycemia. So how do you diagnose? What is the score or scale that is being used? This is the Bush-Watzowski score or the point scale which has been used. So it involves almost 6 parameters: temperature, any precipitant history, then CNS effects, including psychosis, or is the patient is in coma. Depending on that, mild agitation to coma, they grade it with 10, 20, and 30. Gastrointestinal aspect, diarrhea, nausea, severe symptoms like unexplained jaundice, 10. Tachycardia and atrial fibrillation, so this is graded from 5 to 25. Heart failure with pedal edema, basal rales, and pulmonary edema, 5 to 15. So based on this, you have a score of up to more than 45. So less than 25, thyroid storm is unlikely. 25 to 45, it is impending storm, and more than 45, it is thyroid storm. Okay, so what is the differential diagnosis? Most of the time, you need to make sure if the patient has taken some other medications. Psychotic medications can lead to neuroleptic malignant syndrome, malignant hyperthermia, severe infections, acute mania with catatonia. So those are the differentials. Supportive care. IV fluids, cooling blankets, maintain the temperature, maintain ventilation, oxygen therapy, maintain your electrolytes, then sedation if needed, and drugs. What are the drugs you will give and what are the mechanism? First, propylthiouracil, methimazole, iodine, propranolol, hydrocortisone. So these are the drugs which are commonly used. Propylthiouracil 500 to 1000 milligrams, and then that as a loading dose followed by 250 milligram every 4th hourly. So this acts by blocking the new hormone synthesis. It blocks the conversion of T4 to T3 as well. And methimazole, this is 60 to 80 milligram per day. It also blocks the new hormone synthesis. Propranolol, same dose every 4th hourly, 60 to 80 every 4th hourly. The mechanism of which it acts is, one is it blocks the T4 to T3 conversion. Another, it prevents heart failure as well. And iodine 5 drops orally every 6th hourly. So do not start until 1 hour after thyroid drugs are being initiated. So remember, the first drugs will be propylthiouracil, then propranolol, then you can go ahead with iodine. So it also blocks the thyroid hormone release. These patients will also have associated adrenal insufficiency, so supplement with hydrocortisone. 300 milligram IV bolus followed by 100 milligram every 8th hourly. So this along with supplementing or supplementing for the insufficiency, it will block the conversion of T4 to T3 conversion as well. So these are the drugs and treatment for thyrotoxicosis or thyroid storm. So next we'll go ahead with myxedema coma. So this is a life-threatening hypothyroid complication with multi-organ dysfunction associated with altered mentation. The mortality ranging from 25, it is variable actually. So it's up to 20 to 25%, and it results from long-standing untreated hypothyroidism. Usually it can present at any form from mild to severe form as well. The precipitating factors, remember, any infections, any trauma, not taking proper medications for non-compliance, burns, other cardiac failure, any stroke, or some medications like anti-TNF therapy. Two drugs you need to remember: amiodarone and lithium. The mechanism of amiodarone is that it inhibits T4 to T3 conversion and releases excess iodine. So this is the mechanism of amiodarone induced myxedema coma. Lithium, it causes it inhibits thyroid hormone release and CMP production in response to TSH, so exaggerated TSH response. So these are the various drugs, other drugs like phenytoin, rifampicin, diuretics. So these are the precipitating factors. Clinical features: altered mentation resulting in complete augmentation of the mental status. The skin can be coarse and dry, hypothermia, hypoglycemia, hypotension, bradycardia, other ECG changes like blocks can happen. There can be atonic GI constipation, bladder, bladder disturbances. There can be effusions, pleural, pericardial, peritoneal effusions can be there, and intolerance to cold. So all those are clinical features. Differential diagnosis. So these are the differential diagnosis. Any patient who's septic, hypoglycemic, malnourished. So these are post-cardiac arrest status. So these are differential diagnosis. So how do you diagnose? Okay, there will be a subnormal free T3 and T4 levels with an elevated TSH that will be more than 20 most of the times. Okay, that is kind of confirmatory along with the typical clinical signs and symptoms. How will you treat? Treatment is mainly supportive and supplementation of the thyroid hormone. So what are the complications? So patient will be hypoventilating. So you'll have to maintain the ventilation. Hypothermic, maintain the temperature. Hypoglycemic, supplement glucose. Hyponatremia can be there if the patient's in altered sensorium, supplement with hypotonic saline, and treat the underlying precipitative cause. Avoid all if the patient uh, is in altermentation, or try to avoid sedatives. Intubated patient, it depends. Avoid sedatives, hypnotics, and narcotics as much as possible. The ultimate treatment would be supplementing T3 and T4 along with glucocorticoid supplementation. So because these patients who have a thyroid hormone deficiency also have an associated glucocorticoid deficiency. So always supplement thyroid along with hydrocortisone. So which is the preferred one? Preferred one is T3. Okay, a loading dose of 5 to 20 micrograms IV followed by a maintenance of 2.5 to 10 micrograms 8th hourly. Okay, so this acts early. So the clinical improvement with T3 occurs as early as 3 to 4 hours compared to T4. T4 takes a longer time. So the action begins at 24 hours. So always remember, if T3 is available, that will be a better therapy. But if T3 is not available, either you can begin with T4, a loading dose of 200 to 400 micrograms, followed by 1.6 microgram per kg body weight. So this is the dose that has been recommended. Okay. So along with that, because of coexisting primary or secondary adrenal insufficiency, give hydrocortisone 200 to 400 milligram IV every day. So it can be given every 6 or 8 hourly. So this can be discontinued. So once the patient state is improved, you have to continue with supplemental doses. So that is about myxedema coma. The next topic is sick thyroid syndrome. So this is an acute reversible state occurring in almost 15% of hospitalized patients. It is one of the defense mechanism to prevent catabolic status in an already calorie deficient state. So why does this happen? So it's because of the patient is critically ill. Most of the time in sepsis, there is elevated cytokines, period of starvation, there will be increased cortisol levels. The main issue is with the peripheral conversion of T4 to T3, which is impaired. So this enzyme, the peripheral 5-mono-deiodination is inhibited. So what happens is that T4, almost 70 to 80% of T4 gets converted to T3 in peripheral tissues, and some of which gets converted to reverse T3. So this is the normal phenomenon. This 5-mono-deiodinase enzyme is responsible for this conversion. This step is blocked. So most of T4 gets converted into reverse T3. And the clearance of reverse T3 is also impaired. So that is why it is known as low T3 or high reverse T3 syndrome or sick thyroid syndrome. It is also known as non-thyroidal illness. Okay. So rapid decrease in free T3 occurs 4 days, at least 4 days. Increase in reverse T3 occurs at 12 hours and it normalizes. Once the patient state is improved, it normalizes. The degree of illness is proportionate to the degree of suppression of the TSH. And ideally, after the patient condition improves, recovery happens 24 to 1 to 2 days later on. So looking at the mechanism, so why does this happen? It happens at various levels. If you look at hypothalamus, because of malnutrition, sepsis, inflammation, there is decreased TRH. In pituitary, because of cytokines, there is decreased TSH. In plasma, there is decreased thyroid binding globulin. And tissue uptake, there is decreased uptake of the T3 and T4 as well. Okay, and there is abnormality in the transporter expression. Intracellular deiodination occurs. Okay, D1 is the beneficial receptor, whereas D2, but D1 is decreased and there is D2 which is increased. Okay, and the nuclear thyroid receptors are also altered. So these are the various mechanisms that have been described. So this is something very important that you need to understand. So in various degrees, like in sick thyroid syndrome, it can be mild, moderate, severe, and as the patient recovers, most of the hormones normalize. So first look at TSH. So this is TSH and this is the normal range. So when we look at TSH, it is almost in the normal range in mild, moderate, and in severe, there is a mild dip. And then it kind of normalizes. It is almost in the normal range in every point of the severity of illness. You look at T3. The T3 is low. So low T3, that is why it is known as low T3 syndrome. From mild, moderate, severe, there is kind of low T3. So you look at T4. T4 in the mild stage might be normal, but as the severity increases, the T4 level drops down. Severe level T4 drops down. That is why low T4 indicates a poor prognosis. So, and as recovery occurs, T4 normalizes. Look at reverse T3. So, reverse T3 is always in the higher side. So this graph is very important to describe your hormonal levels in every stage of the sick or every stage of your illness. And low T4, I already mentioned, it indicates poor prognosis. The severity of in severely ill patients manifest with low T4 and TSH. So in severe condition, the TSH will be mildly low and the T4 levels will be very low. So if you are having a TSH level in extremes, okay, if it is like most of the time we saw that the TSH is always in the normal range. So there can be a very slight decrease in the TSH, especially during the severe stage, or there can be a mild increase also. But if it is beyond extremes, like less than zero point 0.1 mu per liter or more than 20, then you have to consider either it's hyper or hypo. It's overt hypo or hyperthyroidism in that scenario. And do not suggest CQ thyroid status in extremes of TSH levels. Okay, more than 20, suspect overt hypothyroidism. So, is this of any kind of like value because of the low hormone levels? Does it require supplementation? No, it indicates some kind of prognosis, poor prognosis to the patient, but supplementation with thyroxine or T3 does not provide any benefit to the patients. So, in acutely ill patient without clinical signs, do not treat sick thyroid status. There is no reduction in the mortality with thyroid hormone supplementation. Next, we'll go into adrenal disorders. So, some basics about adrenal. So, this is the hypothalamo-pituitary adrenal axis. So, the hypothalamus produces the CRH, pituitary produces ACTH, and the adrenal, okay, produces the cortisol. Primary disorder, adrenal, secondary pituitary, and tertiary hypothalamus. So when you are classifying adrenal insufficiency, it can be primary, secondary, or tertiary. And CIRSE is a relative adrenal insufficiency. Okay. And it can be classified as acute or chronic depending on the duration of the symptoms. The prevalence, if we see in critical illness, the adrenal insufficiency is up to, relative insufficiency is up to 30%, especially in shock, it increases up to 40%. Absolute insufficiency is very, very rare. So there is always a relative insufficiency. So what are the functions of cortisol? We all know that it's a hormone flight and fright response. Okay, it is mainly involved in gluconeogenesis, anti-inflammatory effect, maintenance of vascular tone, endothelial integrity, and it increases the sensitivity to catecholamines, reduction in nitric oxide-mediated vasodilation, and modulation of angiotensin synthesis. Those are the various functions of these hormones. So what is the definition of adrenal crisis? Definition of CIRSE. So it is defined as, adrenal crisis is defined as life-threatening form of adrenal insufficiency where the glands cannot produce enough cortisol to meet the body's demand, especially during stress. What is CIRSE? This is occurring in critically ill patients due to dysfunction of the hypothalamo-pituitary axis due to altered metabolism, tissue resistance to corticosteroids. Okay, so this is a relative insufficiency, and in periods of stress, the body response may not be adequate to adequate. Okay, that is CIRSE. So etiology broadly classifying into local when you're thinking about adrenal gland. So anything related to the adrenal pituitary, so renal cell carcinoma or Addison's disease, tuberculosis, sarcoid, amyloid, hemochromatosis. So you can, or any neoplastic invasion, so trauma, so or shock, so all those things related to adrenal. So in general, sepsis, TB, fungal infection, Meningococcal sepsis is something that you should not forget. HIV, TB, HIV, meningococcal infections. So all these things you have to remember. Postpartum pituitary necrosis is another important thing. Other things, vascular etiology, aortic aneurysm, arterial embolism. Drugs. There are a lot of drugs which we use in the ICU which can suppress the adrenal glands. Etomidate, everybody knows, fluconazole, ketoconazole, rifampicin, phenytoin, okay, and acute withdrawal of the corticosteroid as well. So these are the various drugs that cause suppression of the cortisol. So insufficient, if the patient has been on prolonged steroid supplementation and abruptly weaned off, so that is one of the etiology, and it can be an increased demand, which we already saw. So the normal cortisol levels, when we see, it's early, there is a diurnal variation always, and it is advised to take the cortisol between this times. 8 a.m. is the normal time that we have to check in. So at that time, the levels are usually 10 to 20 microgram per deciliter. And the normal cortisol levels 10 to 50 nanogram per liter. Normal production of cortisol is between 15 to 20 milligrams per day. And during stress, there can be an increase in requirements up to 50 and 150 per day. Okay, so you will have to exogenously supplement. Okay, there is a sick day rule, something like sick day rule, when there can be an increase in the requirement. In burns, there is some increase in requirement of the cortisol. So clinical features, when we are looking into, you have to know about the acute, chronic, and SERSI relative. So when we are talking, the symptoms can overlap actually, the clinical features. Acute, the patient will be frankly in shock, that hypotension, not responding to fluids. This is very important. Along with other features, hypoglycemia will be there, hyponatremia, hyperkalemia, metabolic acidosis, hypoeosinophilia, hypoglycemia, and eosinophilia. So these are the important features you will be able to appreciate. In chronic phase, hyperpigmentation will be there because of increased ACTH secretion. There can be hyperpigmentation in the skin. Okay, and other features, altered consciousness, okay, normochromic anemia, hyperdynamic circulation, diarrhea. So these are other features. So when in ICU, the typical features are non-venability from vasopressors. That is one of the indications. The patient would have improved from sepsis, recovered almost, but requiring a mild dose of vasopressors. That is one of the features of SERSI. So why does this happen? The mechanisms which is leading to SERSI, there are four things that you need to remember. So one is altered synthesis of cortisol, that can be due to necrosis, that can be due to production defects, some esterification in the cortisol, inhibition of steroidogenesis. This can be due to DIC, shock, other cytokines. So decrease in synthesis, altered CRH and ACTH. This can be due to again necrosis and due to various other factors. Okay, alteration in metabolism. Okay, decrease cortisol transport, decrease cortisol breakdown. Again, the binding proteins can be deficient. There can be defect in the glucocorticoid inactivator 5 reductase enzymes, and tissue resistance. So remember these four mechanisms alone. So what happens in SERSI? There is an acute phase and there is a chronic phase. So the cortisol levels in initial phases of critical illness is elevated because of various factors. It is not just because of ACTH elevation, but because of various other factors like cytokines, marked inflammation, neuropeptides. So all these things cause a elevated cortisol level. So during that acute phase, there will be a transient increase in the ACTH levels, but after some time, the ACTH levels falls down. So there is a dissociation between plasma cortisol and ACTH levels. Then what happens in the chronic phase? Gradually, as the ACTH levels are low, there is persistently low, there is adrenal gland that is less stimulated and atrophy of the adrenal gland, which happens. And gradually, there is a decrease in the cortisol secretion. So this happens in the chronic phase. So this the plasma levels of cortisol will be proportional to the duration of critical illness. So these are the two phases. So when we look in detail about this, so prolonged illness, there is initial hypercortisolemia resulting in decreased ACTH, loss of ACTH mediated stimulation of the adrenal cortex. So this gets atrophied. So what are the reasons why hypercortisolemia? Also high bile acids, other exogenous glucocorticoid ligands. So all these things cause negative feedback and sustained inhibition of pituitary as well as CRH. Okay, ACTH as well as CRH will be inhibited, and other drugs, whatever we are giving in the ICU, etomidate, opioids, azoles, rifampicin, phenytoin. So all these inhibit. Okay. So gradually there is a decline in the free cortisol as well as low cortisol levels. There will be other symptoms. Okay. This is the main pathophysiology of CIRSE. So how will you detect it? How will you detect? So if you find a cortisol level that is less than 10, that is diagnostic of CIRSE. Or if you find a random cortisol level that is more than 10, but still the patient has features of hypocortisolism, you do a ACTH, okay, ACTH stimulation test. Okay, how is it being done? So 250 microgram of synactin is given, IM or IV. 30 minutes later, first a baseline cortisol is taken, and then 30 to 60 minutes later, you check the cortisol level. The difference between the cortisol prior to administration and after the stimulation, that is 1 hour after stimulation, if the delta cortisol level is less than 9, that is ACTH fails to stimulate the production of cortisol or increase the production of cortisol. So if your delta cortisol is less than 9, that indicates CIRSE. Okay, so random cortisol less than 10 or a delta cortisol less than 9 by co-synoptin simulation test. So so how do you treat that? Before that, patients who are the patients at risk of developing this relative insufficiency, especially patients who are on a regular daily dose of prednisolone more than 10 milligrams per day or equivalent in the last 3 months, at least for 15 days. So if they have taken this 10 milligrams of prednisolone at least for 15 days in the last 3 months, they are at risk of developing this insufficiency, especially when they are undergoing some kind of surgery, they need supplement. For minor surgery, it is recommended 25 micrograms at induction, moderate 25 at induction, followed by 100 continued for a period of 24 hours. For major surgery, usually 25 milligram at induction, 100 milligram per day for the next 2 to 3 days. So this is the advised recommendation in perioperative period. So when you're looking at a critical ill patient, obviously the patient can be in crisis. In that scenario, either it's primary or secondary, you supplement 100 milligrams bolus followed by 200 milligrams IV every day. So how do you taper it? This is on first day. Then you can slowly taper it down to 60 milligram IV per day. So this is, and follow up with the endocrinologist. In refractory septic shock, you should not do a stimulation test. Always remember there are various studies that are available starting from NN to adrenal. So we have evidence in septic shock, refractory shock, evidence to supplement with the steroids, stress dose of steroids to 200 milligram every 24 hourly. We give it at either as an infusion 200 milligram or 56th hourly. Okay. When hemodynamic improvement happens, then you can stop it at 5 to 7 days. So in prolonged illness or critical illness, in CIRSE, what is the recommendation? In SERSI, the recommendation is to give 60 milligram IV 24 hourly. That is 40 milligram in the morning and 20 in the evening. Okay. And later on, as the clinical improvement happens, taper off, follow up with the endocrinologist. So that is about